And so I did that rotation, and literally, Ryan, within 2 days of doing that rotation, it resonated with me, and I thought, this is what I want to do.
Yeah.
Because it touched on orthopedics, touched on neurosurgery, touched on neurology, touched on function, touched on biomechanics, which is what I liked about physical therapy way back in high school.
Mhm.
And it just really kind of hit everything I liked and had an interest in.
Dr. Bob Rinaldi, welcome to eShadowing. How you doing?
Good. I'm doing good today. Thanks for letting me be here.
I am excited for you to be here. For all of the students joining us as you make your way in, make sure you change your chat settings to everyone instead of host and panelists. And let us know where you are watching from. Where in the world or country are you watching from? And more specifically, if you are interested in physiatry, which is what we're going to be talking about today, physical medicine, rehabilitation, physiatry, you guys are having an identity crisis. I don't know what to call you guys.
We're not sure what to call ourselves either.
How did you, Dr. Bob Rinaldi, figure out that you wanted to be a physiatrist?
Yeah, good question. So I went to med school originally anticipating going into neurosurgery. And
Okay.
yeah, so had a natural interest in neurology. In high school, I'd thought about physical therapy. I knew a physical therapist. Thought that sounds kind of interesting, but kind of as I approached medical school, I was thinking neurosurgery. I like working with my hands. Felt I had a pretty good skill set for that. Got into med school, obviously, and started doing my rotations. I absolutely loved neurosurgery. I found out I loved orthopedics and I loved pediatrics. What am I going to do with this? I thought, well, maybe pediatric neurology. Figured out pretty early. I didn't really want to be a surgeon once I rotated through surgery. The hours didn't really fit my personality, and it's pretty brutal. So focused on peds neuro. Decided to go into that. Went into general pediatrics for my residency.
Okay.
Thinking I would do a fellowship in peds neuro after that. And decided I'd try a rotation in peds rehab. Thought that would be beneficial. If I'm going to be a pediatric neurologist, probably be good to learn about neurotrauma and brain injury and spinal cord injury and some of these things that peds rehab guys see. And so I did that rotation, and literally, Ryan, within 2 days of doing that rotation, it resonated with me, and I thought, this is what I want to do.
Yeah.
Because it touched on orthopedics, touched on neurosurgery, touched on neurology, touched on function, touched on biomechanics, which is what I liked about physical therapy way back in high school.
Mhm.
And it just really kind of hit everything I liked and had an interest in med school. So it really resonated with me in that regard. And then just the basic philosophy behind what we do in rehab, where we're treating the whole person and we're looking at function and integration back into society and back into their lives. That really hit me as being, kind of an epiphany for me. That's why I went to med school, right?
Mhm.
I like
Yeah.
pathology, I like curing things, but really what I really found I liked about med school is seeing patients get back to doing what they were doing before they ever got ill. So it really, I think it hit me as being the ideal subspecialty for me to pursue. So I did a residency in general pediatrics, completed 3 years of that, and then flipped into a residency in general physical medicine and rehab and completed 3 years of that, which made me board eligible for both the general PM&R as well as the pediatric subspecialty boards. And that's how I got where I am.
Nice. It's interesting. I think more students, pre-med students, medical students, and residents, even as they're going through potentially thinking about fellowship, need to do more thinking about that aspect of their patient journey of, are you okay that your patients may not get better? Or are you the type of person just your reward system comes from seeing them get better, and that makes you happy and helps you thrive, right? My wife is a TBI concussion specialist neurologist, general neurologist, and a lot of her patients don't get better, and
Yeah.
it's really hard for her, right? Neurology is hard.
Yeah.
And she does her best, and she's one of the best in the country doing what she does, and it's still hard. The outcomes are hard. And so I think there needs to be more emphasis on that, right? It's not just, do you like neurology? Do you like pathology? Do you like whatever? It's what is that patient journey like for you, and where do you want to see see your patients? Do you want to see them walk out of the hospital, or are you okay being by the bedside when they pass as well?
100%. I agree 100%. I do a lot of interviews of medical students for residency
Mhm.
training, and I've been doing that for years. And one of the biggest things I like to tease out during those interviews is what makes this person tick.
Mhm.
Do they have insight into those types of things? What really is it about this person that makes them want to do rehab? Because you're right, a lot of our patients don't get better. They don't get fixed. I've
Mhm.
seen plenty of traumatic brain injury patients who don't communicate after the injury. They don't walk again. They don't do these things. And the idea behind rehab is, yes, we accept that, but we're going to make the best quality of life we can given the circumstances. And it's fascinating. I know a lot of people that doesn't sound great, but I tell you what, the biggest joy I have is when I've got a traumatic brain injury patient who's been basically in bed, in a hospital, in the ICU, in the inpatient rehab unit, when they first smile. It just blows everything away. The parents are thrilled. They finally see a glimmer with the child. And it's those small gains like that mean the world to these parents. And it's a side of medicine you don't really see in other areas. And it's to me, it's kind of what rehab is about. I know a lot of people think, oh, horrible stuff, but no, man, it's the beautiful gains like that we really thrive on in what we
Yeah.
do.
Yeah. What's the worst part about the job?
About being a
Besides
doctor or about
besides
rehab?
charting. But
Besides
for rehab, yeah. Besides charting and insurance. Those are
charting
the
and
easy
insurance,
ones.
yeah, those are the very easy ones. That's top of the list. Um, the worst part of the job, I would say there is inherent stress in these situations. You've got a perfectly normal, for instance, a perfectly normal 15-year-old goes out for a bike ride, and all of a sudden the whole world changes. You know, they get in an accident. The world's turned over, not just for that patient, but for the entire family and extended family and friends and their families. That's hard. That's hard. So the initial hit, I think, can be stressful, can be tough. Those initial discussions with families can be hard in those circumstances. But again, once the parents begin seeing gains, and once we begin seeing gains as a team, you really begin to take on a very hopeful approach to what's going on, and a very optimistic approach to where things are headed. And the vast majority of patients do really well in the traumatic brain injury world. Um, so that's probably the biggest stress, is having to upfront deal with very stressful situations for families. And then, occasionally patients do pass away. I've had talks with plenty of families in the ICUs before about, lack of functional recovery prognosis for these kids, and making those decisions about withdrawing life support with the intensivists. We do play a role in that process at times in terms of painting a realistic picture for families about what the outcome most likely is going to be. So we do get involved in that side of things. Those situations are probably the most stressful things we deal with. The job itself is not stressful. Rehab physicians are notorious for having a pretty good life. It's really a very good job in that regard.
Yeah. How do you keep work at work? The emotions of work at work, if you can.
That's hard. I made a very clear, conscious decision when I started my training that I was going to separate work from life. And I've had a very supportive family in that regard. So I'm pretty good about keeping things at work. And then when I get home and walk through the door at home, I'm taking on my life outside of work. And I have just become very cognizant of that distinction, and been very good about keeping the two separated. And again, I have a very good family that's supportive of that as well, and supportive of me when I'm not in the best of moods or stressed out about things. So that
Yeah.
helps.
Yeah. Well, I know you have a presentation for us. I'll let you take that away if you want to share your screen.
Okay, so yeah, the intention of this, what I really want to do is kind of partake understanding of what pediatric or physical medicine rehab is. I'm not going to delve into pediatrics, which is my subspecialty on pediatric rehab, but really what PM&R is, and how we look at patients, comparing the PM&R model with the medical model, and then discuss a little bit about how to get to where we are. If you're interested in the field, how do you, what does it entail to get into PM&R? So pretty straightforward stuff. Shouldn't take a horribly long time. Oops. Okay, so what is PM&R? I don't know how many of you out there, it looks like 57 people are aware of what PM&R is, or physiatry. as we're called. We are physiatrists. And it's funny you mentioned that earlier, Ryan, because we have had really robust discussions at the academy level about what the hell are we called.
Yeah, pick
And
one. Pick one. Come
it's
on.
ridiculous. Yeah, I've been called a podiatrist. I've been called a psychiatrist. Like I'm a physiatrist.
Yeah.
So what are we? Well, physical medicine and rehab, PM&R. We are a subspecialty in medicine that aims to enhance and restore functional ability and quality of life to those patients with physical impairments or disabilities affecting the brain, spinal cord, nerves, bones, joints, ligaments, muscles, and tendons. So we're not really a specialty that looks at a cure. The goals for what we do are to maximize that patient's functional independence, whether it's activities of daily living, self-care activities, whatever the case may be. That's the thrust of what we do, is we're looking to improve function. And I'll talk about function in a second. So my academy, which I've been heavily involved in for the past 20 years, we do have a vision statement that I think helps clarify what we do a little bit more. So we are essential medical experts in value-based evaluation, diagnosis, and management of neuromusculoskeletal and disabling conditions, disabling being a key word. We're indispensable leaders in directing rehabilitation and recovery and in preventing injury and disease. And then we're vital in optimizing outcomes and function early and throughout the continuum of patient care. Throughout the continuum is a critical point here. So we are involved from the very onset of the illness, the impairment, whatever the case may be, all the way to this patient being back out in the community and managing them longitudinally. So we take care of the patient across the entire continuum. For instance, traumatic brain injury, we typically are consulted within 24 hours of a patient being admitted to a hospital for traumatic brain injury. Doesn't really matter how severely affected they are. They may be, on a ventilator, fully sedated in a coma. That's okay. We still have things we can do, and I'll touch on that towards the end of the talk about kind of that scenario. So we're involved from the start, and we follow those patients longitudinally. That's a key component of what we do. We look to restore maximum function lost through injury, illness, or disabling conditions. So it's not just injury based, but also illness based. I think the example on most people's minds these days is COVID, long haul syndrome. So many of the models for long haul syndrome management have been developed by physiatrists because of the longitudinal aspects and because of how COVID affects function. We treat the whole person, not just the problem area. Again, if you're thinking about function, you're thinking about the whole person, right? So you may have a patient with an amputated upper extremity or lower extremity. That's fine. We do manage the amputation, no doubt about it. We help with the prosthetics. But we also are looking at getting this patient back to school, getting them back to work, getting them back to playing softball on the weekends, whatever it is they do, whatever their life entails. That's part of what we do too, not just managing the limb deficiency itself. We lead collaborative efforts with a team of medical professionals. We work very closely with physical therapy, occupational therapy, speech therapy, rec therapy, social work, neuropsych, and so on. And we do provide adjunct non-surgical treatments in medical management. So we don't just manage the team. We also we get involved from the medical perspective. We do provide medical management for patients, and there's a litany of things that we do from the medical perspective. So we're not just looking at function and managing therapy plans. We also are involved in medical management of patients. So optimizing function and daily living is the goal. And as I like to tell my residents, the way I look at it is the intensivists and these other docs save the patient's life, but we get them back to their life. That's our whole point, because we want to get them back to living again. So, kind of in a nutshell, the goal of rehab medicine is to minimize the health impact of physical and cognitive impairments on an individual while maximizing functional capacity and performance. Again, whether that's recreational activities such as adaptive water skiing is in this photo, adaptive sports, adaptive recreational activities, or getting back into their place of employment, the things they love to do for a living prior to their illness or their injury. So it's a big role in what we do. And again, you're going to hear me say function, function, function over and over, because that's really the crux of what we're doing here. And it's awesome. It's so cool to take patients who, have a disabling injury, motor vehicle accident, spinal cord injury, and getting them back to doing the things they love. It's really a fantastic journey for the patient, for their families, and for us. So what is function? Well, function is the activity for one, or for which one is specifically fitted or employed. So it's the daily things they do every day. We get up in the morning, we brush our teeth, we put our clothes on, we go to work, we take our kids to school, we get home, we make dinner, we are involved in exercise programs, whatever it is. That's all function. That's everything we think about and look at as rehab docs. So we're really focused on those things. Functional limitations, what can affect function? Well, there are a lot of limitations, including biological, psychological, and emotional factors. So when we're looking, oops, sorry about that. So when we're looking at getting a patient back to function and getting them back to things, we take all those into account. We take into account the physical impairment, the underlying pathology. We take into account their psychological state and their emotional state. We take into account social dynamics around them. What is the family dynamic like? What is their social situation like? All these things play a role in getting them back to doing functional activities and getting back to what they were doing previously. Sometimes that can be super easy. Most families are pretty supportive. Sometimes it can be super dysfunctional, and we have to work through those things. But that's why we work as a team. That's why we have social workers. That's why we have psychologists involved, is because sometimes there are very dysfunctional situations that we have to kind of work through to get patients back to full function again. I really like rehab. I'm going to be talking about the team shortly. I really like rehab because of the team approach. We truly work as a team, as I mentioned previously. I grew up playing sports my whole life. I've always appreciated teamwork. I've always appreciated different perspectives attacking a problem, and different roles attacking a problem. So we truly are a team approach to doing these types of things. When we talk about function, we talk about functional domains, mobility. So how are they transferring? How are they transitioning? Do they have bed mobility? How are they getting on and off the toilet? If they're a wheelchair user, how are they utilizing that wheelchair, not just in the home, but in the community? What is community-based and school-based mobility like? Can they get around their place of employment? Can they get around the school? If they have classes on the second floor, is there an elevator in that school or not? So there are a lot of different aspects that go into mobility when we think about mobile function. Self-care, we look at self-care activities, including eating, dressing, bathing, grooming, and so on. We think about communication as a functional domain as well, whether it be verbal or nonverbal communication. So how do they communicate effectively to express their needs, their desires, and their wishes? We look at social function and activities of daily living, recreation and leisure activities. What do they like to do? What are their school skills like? How can we intervene at the school setting to make them more functional and successful in school? What is work performance like? If the patient was, say, a construction worker prior to their bilateral lower extremity amputation, okay, their skill set is in construction. What can we do to adapt to that once they've recovered from their trauma? Will they go back to doing hard labor? Maybe not, but what can we do in the realm of construction that would be satisfying for them? So those are the types of things we look at when we're thinking about functional domains and the types of things we think about. When we think about rehab, we are always looking at the rehab model versus the medical model, and we hear that over and over when we're talking and with our residents, with our trainees, as to what is the biomedical or medical model, what is the rehab model. Well, the biomedical model is what we're all learning in medical school, right? It focuses on the biological and physical impacts of the aspects of the illness and disease, with the goal of diagnosing, treating, and curing. So you give medication A to improve condition B, or hypertension, for instance. Pretty straightforward. We diagnose the hypertension, we find a treatment that's going to work, we manage the patient accordingly. The rehab model really is application of those types of concepts and therapy-based interventions with the goal of improving functional ability and capacity and performance. So we apply tone management strategies, for instance, such as Botox injections, surgical rhizotomies, tendon lengthenings, the types of things we manage spasticity with, in conjunction with therapy to improve upper extremity function and personal capacity. So I can't fix the underlying spasticity or the underlying tone in that patient. I can't get rid of that. That's there. But what I can do is mitigate the effects of it and improve the patient's function. So that's kind of how we look at things. We're more focused on function as opposed to curing that spasticity, which I can't do yet. But how can I make this person more functional and improve their quality of life? So again, we utilize the medical model, but the end goal is functional capacity and performance, which again can be pretty empowering stuff. Oops, try to advance my slide. There we go. So the working construct of the rehabilitation model really is based upon the World Health Organization classification. They had the original classification in 1980. This is the original one I trained with. And we defined impairment as any loss or abnormality of psychological, physiological, or anatomical structure or function. The disability is any restriction or lack resulting from that impairment to perform an activity in the manner or within the range considered normal for a human being. And then handicap is a disadvantage that results from that impairment or disability. It limits or prevents them from fulfilling a role in society. So it's the societal effect for that individual, basically, that defines the handicap. We worked off these three definitions for the longest time. And kind of worked within that construct. And then the World Health Organization in 2001, about 20 years later, redefined this, and I think it's a more appropriate definition. The disability is the impairment to the body, part, or organ system level, activity restrictions at the person level, or participation restrictions at that person and society level. So that takes into account physical, social, and psychological factors. It takes into account what we had originally defined as impairment, disability, and handicap, right? That all is sort of tucked now under this umbrella of, quote, disability. We've now defined capacity as the individual's intrinsic ability to carry out a task or action. And then performance is how well do they carry over that ability in their own real life environment. So for instance, we can have a patient come into clinic and walk up and down the hallway and look really good. And then the patient gets home and they're not looking so good when they walk, and they're not walking. They're utilizing the wheelchair. So they have the capacity to ambulate, right? But they're not carrying that through and performing that ambulatory activity once they get home or out in society. They're relying on a wheelchair instead. So that's actually a pretty powerful distinction that we work within quite a bit. Is capacity and performance. And it's a real problem for us because once the patient leaves the hospital, say, and gets back home, many times their capacity to do things drops off. I mean, they just quit doing things. They're not performing those things. And subsequently, their capacity can even suffer from that. So capacity and performance are very important concepts for us as rehab physicians when we're looking at patient ability.
What causes that? The way you said that, I'm sitting here thinking, if they can walk down the hall at the doctor's office, but they can't walk down the hall at their house, assuming the surface, right? It's carpet versus hardwood versus whatever, right? Assume that's out of the picture. Like, what's the difference? Is it psychological, or I don't understand what that difference is.
It can be. It can be psychological. Typically, it's the physical barrier, but it can be psychological. And that comes down to what's easiest for the family. It may be easier for them just to put, the kiddo in a wheelchair or the patient in a wheelchair, bring them into the dining room from their bedroom.
Convenience.
Convenience, big time convenience. And we see that a lot, actually. I'll talk to parents, okay, can your child get dressed in the morning? Yeah, they can get dressed,
but it takes too long, so I just do it for them.
It takes too long, exactly. So I just do it for them. It's like, wait a second. So they have the capacity to do it, but you're not letting them perform that activity. Why? Yeah. We're in a hurry. I've got 3 other able-bodied kids. I got to get everybody to school. Life happens, right? Life happens. Yep. So I get it. So those are typically the types of things that we run into between capacity and performance.
Okay.
And we have to work around those. Oops. So the old construct, is PM&R. We'd use physical interventions to affect our impairments. We'd utilize adaptive equipment, durable medical equipment, compensatory strategies to help with the subsequent disability from that impairment. And then to address the handicap, we'd get work evaluations. We'd tie patients into community resources. There are multiple federal laws now that make environments less restrictive for people with handicaps and facilitate function in the workforce for folks with handicaps. This was the old construct we worked with from the WHO. It was put in place back in the 1980s that worked within impairment, disability, and handicap. They subsequently changed that in 2001, and I think a much better model now, where we're looking at the health condition and body function and structure. And we're looking at how that is affecting activities and participation, while also thinking about environmental factors and personal factors. So just like we were talking about, Ryan, okay, they're not walking down the hallway because there are multiple personal factors here. It's a convenience issue for the family, so on and so forth. So we need to look at those types of things when we're now working within the rehab model or the working construct of what we do in rehab. We're now taking those things into, I think, stronger account now when we're trying to work with patients. So if you haven't guessed at this point, we are part psychologists too. We have to work within that.
I think all good physicians are.
All good physicians are. It's a great point. Absolutely. Get to know thy patient.
Mm-hmm.
It is a team-based approach. I am from Dallas, therefore Cowboys are my model. They're
Sorry.
not the best team in the world, right? We're getting there. We'll give it time. So it is a team-based approach. My team, literally my team, every day when I go to work consists of a physical therapist, OTs, speech therapists, rec therapists, music therapists, social workers, care coordinators, other medical subspecialties, psych, neuropsych, home health agencies, community health agencies, vocational rehab agencies, and orthotists and prosthetists. Every week I'm interacting with every one of these folks. If not every day. And it is a team approach. Again, these patients have complex issues, and it really does take a team approach. And that's what I love about it. Not that I'm Dak Prescott, God forbid, but we do quarterback this. We've got to have the players on the field doing their jobs appropriately to make things work for the patient. And it's just a blast. If you like teamwork, it's really a very, very fun environment to be in. Why is the PM&R model important? Well, obviously we can't fix everything in medicine, right? And the whole goal of medicine is to make the person whole again, and that includes function. It's directed and goal-driven. Interventions are meaningful and conceived around functional goals. Will intervention A or procedure B lead to better incorporation of the hand? That's the whole goal, not procedure B makes the hand look better. The surgeons I work with, aesthetics and making things look better, and gee, I can do the surgery because I can do the surgery. Unless there's a functional goal for that surgery, we're not going to do that surgery. I think that's particularly important in pediatrics too. So we have a common goal of improved function, independence, and quality of life. So what do we see? We see a lot of stuff. We see neurotrauma, including traumatic brain injury, spinal cord injury, strokes. We work heavily in the neuromuscular disorders world. That's my background. My background is neuromuscular rehab. So muscular dystrophies, myopathies, peripheral nerve disorders, and neuropathies. On the adult side, those continue. We throw in ALS, multiple sclerosis, and other neuromuscular conditions. We're heavily involved in these areas. Musculoskeletal trauma and injury, including low back pain, other MSK aches and pains, rotator cuff tears, things like that. Many physiatrists go into sports medicine, where they're working with concussion, musculoskeletal injuries. Many of them are team physicians, not just at the local levels, but also at the national level. Pain, that's a big part of what we do, whether it's musculoskeletal, neurological, or even functional neurologic disorders with pain. Limb deficiency is a large area we work within, including traumatic and congenital limb deficiencies. We're heavily involved in prosthesis development and management. Gait disturbances, big area in pediatrics is gait abnormalities. There are a lot of reasons why we see that in kids, so we're involved in the assessment and management of gait abnormalities. And then probably newer areas that we're branching into include cancer and oncologic conditions. Cancer rehab is an emerging area on the adult side as well as the pediatric world, as is cardiac rehab. On the adult side, that's been around for quite a while, where adult physiatrists are involved with the cardiac population. It's one of the newer areas in pediatrics now, is where we're beginning to integrate into congenital heart disease, because we're finding out a lot of those kids do have functional problems. So we're in that area. And then pediatric-based conditions, which again is what I do, includes all the above. All of these things are trickling down into pediatrics now. So we do, cover quite a bit of ground in what we do. You can subspecialize within any of these areas, as I'll talk about in a moment, or you can remain broad. Again, I have subspecialized over the years in neuromuscular disorders on the pediatric side, but I also do gait disturbance. I deal with pain. I've got a low back pain clinic where I'm managing those kiddos, and then I work in neurotrauma as well. We get heavy procedural training as rehab docs. So we get trained in electromyography and nerve conduction studies. We get trained in injection techniques, including Botox, neurolytic agent injections. We do nerve blocks where we're injecting steroids and deadening agents, such as triamcinolone around nerves to deaden the nerve. We do trigger point injections for muscle pain. We're trained in intrathecal baclofen pump management, intra-articular injections for pain, and then musculoskeletal ultrasound. We get trained in that for muscle localization and joint injection localization for what I just mentioned. Advanced practice training and fellowships includes interventional pain techniques, including epidural injections, facet injections, neuromodulation, implantation, and stimulation for chronic pain patients, and then prolotherapy for chronic pain patients as well. So you can see we do get trained in multiple procedures that we then employ based upon our particular practice patterns and needs. As pediatric rehab, I do quite a bit of Botox injections and neurolytic agent injections, as well as trigger point injections and intrathecal baclofen pump management for spasticity. Do quite a bit of those. It's a broad-based practice. We see patients in hospital-based practices, which tend to be consult-based. So we see patients in consultation to the intensive care units for neurotrauma, for acquired illnesses such as meningitis, encephalitis, you name it. There are a lot of different things we see in the hospital on a consultation basis. We work in inpatient rehab units and facilities for acute inpatient rehab or chronic rehab needs. Most of the patients in the pediatric world anyways, in the acute inpatient rehab units tend to be traumatic brain injury, spinal cord injury, meningitis, Guillain-Barré, some of these types of conditions. We work in the outpatient ambulatory clinics. I do some basic consults in the hospital, but most of my practice is outpatient, where I hold ambulatory clinics 7.5 days a week. Some docs work in skilled nursing facilities, providing low-level subacute rehab. And then docs do combinations of the above. So there are different practice environments that you can work in within rehab, depending upon what your interests are and what your goals are as a physiatrist. So how does this translate to different care settings? Well, we'll talk about the inpatient. I don't really have any cases per se, but to kind of give you a flavor of what we do. On the inpatient side, we do multidisciplinary coordination of goals, as I mentioned before. From the MD side, we're involved in medical management of tone, agitation, bowel and bladder function, seizures, contracture management. We address motor deficits in our inpatients, cognitive deficits, levels of consciousness, and we apply medications for that. Durable medical equipment considerations, looking at long-term goals and oops, golly, sorry about that, guys. The physical therapist will work on balance, strength, range of motion, motor control, transitions and transfers in and out of bed, in and off the toilet, progressive mobility skills, orientation, orthotics, adaptive mobility needs and such. This is all on the inpatient side. OTs will work on strength, range of motion, coordination, sensory motor integration, fine and most motor skills, self-care ADLs, and so on. And then speech therapists will work on the cognitive aspects of the patient's recovery, including expressive and receptive communications. They'll employ augmentative communication systems if they need to, such as eye gaze systems, voice loops, things like that don't require verbal output from the patient. And then feeding and oral and motor skills. So traumatic brain injury is an example. Again, this is a major population for us on the inpatient side, not just peds, but in rehab in general. So as I mentioned previously, we get consulted 24 hours of admission for a traumatic brain injury patient. So what do? Well, we provide education to the families. This is a traumatic brain injury. This is the part of the brain that's been damaged. These are the MRI scans, CT scans. This is what it looks like. This is what it means. This is what to anticipate moving down the road in terms of, prognosis for similar injuries. We work to prevent secondary physical complications such as contractures, skin breakdown, bowel and bladder dysfunction. We work to manage spasticity and agitation in the patients as they're recovering. Many of these patients develop horrible muscle tone and agitation. We provide neurostimulants too to try to get the patients to wake up. If a patient's in a coma, there are medications that we will trial that stimulate the portions of the brain that are involved in arousal and attention. So neurostimulation trials are what we do in rehab, and the nutritional assessments. So that's kind of the early involvement, acute approach while the patient's in the ICU 24 hours on. We're looking at all these things. And then mid-course involvement as they progress and get out of the ICU and they're doing better. We begin working on progressive mobility. We continue family education. We're thinking about cognitive remediation, behavioral management, OGCOM, feeding, maintenance of physical status, transition to outpatient versus inpatient rehab considerations. What's going to be best for the family? If they're from 9 hours away in West Texas, in a small rural community in West Texas, what's the closest rehab facility for them? What's going to be the best option for them? So we begin that process talking about these things, even while the patient's in the ICU, quite honestly, because it takes time to plan these things. And insurance can be a major headache, making sure that they're even going to cover the costs for this stuff. You asked me what one of my stressors were, Ryan. Yeah, insurance.
Insurance. Yeah.
That's a big stressor right there.
No, I said you couldn't pick insurance.
Okay, on the acute side, inpatient side. Once they get to the rehab unit, we begin working on the goal becomes what is the highest level of functional independence we can achieve that allows safe return to home environment for that patient. So we're looking at modified assistance to independence and gait and mobility. What's the home environment look like? Do they have 12 steps they got to go up to get into the house, much less to the second floor? How are we going to do that? What's the community access like? What's the school access like? And we begin working on all these things on the inpatient rehab unit. Same thing with bathing, feeding, toileting, and dressing. What is it going to look like for them when they get home? What types of things are we going to have to be able to achieve for them to function in the home environment? And then modified assistance to independence with ADLs as well. Ability to sequence needed activities, something as simple as taking their medications. How are we going to do that? How are they going to do meal prep? How are they going to make appointments? How are they going to keep daily schedules? Those are the types of things that we have to think about and address so that we can get them successfully integrated back into home. And we use things like memory assistance strategies and so on to achieve those goals. On the outpatient side, we're designed also around multidisciplinary care and coordination. We mentioned we work with PTs, OTs, speech therapists, social work, care coordinators on the inpatient side. We do the same thing on the outpatient side. For instance, our neuromuscular disorders clinic here, we have PM&R in it. We have PT/OT in it. We have nutrition, ortho, palm, social work, care coordination, cardiology is in our neuromuscular disorders clinic. Same thing with spinal defects, durable medical equipment clinics, spasticity clinics, brachial plexus injury clinic, which is one of my favorite populations. I work with the hand surgeons very closely. I work with my occupational therapists, and I do what I do. I'm down in the weeds with surgeons, making surgical decisions with these guys about what can we do operatively for this patient to achieve the functional goal I want to achieve. And same thing for limb deficiency clinic. The orthopedic surgeons are in that clinic with us, the orthotists, PTs, and OTs. So on the outpatient side, again, it's a very heavy multidisciplinary approach to managing these different populations. Again, I mentioned brachial plexus injury. Well, it's a really interesting disorder. And to kind of give you some flavor about what that can look like. So the brachial plexus is the large network of nerves that comes out of the neck, serves the shoulder, arm, and hand function in terms of motion as well as sensation. It can get stretched and traumatized during very difficult deliveries. And that can lead to permanent sequelae. Typically these patients are born with a flail extremity. The vast majority of these do recover though within 1 to 2 months, but some of them don't, and they can have permanent sequelae, including contractures of the muscles. They can have permanent weakness. They can have joint abnormalities, developmental abnormalities of the joint. Again, these are babies and they're growing and developing. So they can have joint developmental abnormalities. They can have biomechanical abnormalities across that shoulder joint. So even though strength is okay, it's not a good joint. It didn't develop normally. So that can limit how far they can move that extremity. They can have limb length differences, skeletal deformities. A really interesting thing called co-contractions can occur in this population of kids, where if you think about moving a joint, it requires a contraction of a muscle and a relaxation of an antagonist muscle, right? So I want to bend my elbow, I contract my bicep, relax my tricep. For some reason in neonatal brachial plexus injuries, even though these kids can recover strength, sometimes they'll have a coupling of those muscles where if the bicep contracts, the tricep will co-contract. So they won't move the joint. We have no clue why that happens, but we do see it not uncommonly.
It's like crocodile tears. It's like when you eat, you start crying. Like, why are these nerves routed the wrong way?
Right, exactly. And that's a major consideration for why we see this, is the nerves didn't regenerate appropriately. Their end organ targets were messed up.
Yeah.
Abnormal motor cortical or motor cortex mapping and apraxia, where the patient just can't use the extremity like they want to use it. It just won't carry out the task the brain is telling it to carry out. We see that occasionally, and then pain. So a lot of things can go wrong in brachial plexus injuries, and all of these are things that I address as a physiatrist, but I do it in co-op with my hand surgeon. I do it in co-op with my hand therapists. So again, it's a very integrated team approach to these very complex problems in kids. And I can't fix all this stuff, but I can work around it. And there are things we can do as medical subspecialists to make function better for these kids. This is an example of that abnormal co-contraction phenomenon. This was one of my patients in practice in Kansas City years ago, where we asked him to raise his arm out to the side. Okay, when you do that, you activate your deltoid, you activate your shoulder muscles, and all of the muscles that bring your arm down to your side should relax, right? Well, we ask him to raise his arm out, and you can see these muscles bunching up all of a sudden. So he can't raise his arm past this because these muscles are wanting to bring the arm down.
Wow.
It's really a very interesting phenomenon that we see, and shockingly, it responds to Botox injections very nicely. So we would Botox these muscles, let's weaken these guys up, and then we can move that arm overhead. So Botox is a tool we utilize in these conditions, not infrequently. So just kind of one of the simple things we do.
How close to we, maybe this is out of a sci-fi film, like cardiologists, interventional cardiologists can go in and find an excitable, right, focus in an atrium and go and burn it, right? They can find it. What's triggering this arrhythmia, and I can go ablate it, and the patient's cured. How close are we to finding out the path of that nerve that's causing those teres muscles in the lat to fire, and going, I'm going to fry that nerve? And obviously they have other nerve routes to go recruit other motor units, but how close are we to doing what an interventional cardiologist does for arrhythmias for this?
For co-contractions, not very close, because we're not, quite honestly, we're not even sure what causes them. There is the concept, and I think most people think it probably is abnormal rerouting, as these nerves are regenerating through the area of injury. But there's also consideration that it's cortically driven, that the motor cortex did not map normally.
So is it central peripheral is kind of still a big question?
Peripheral, yeah. We're actually working on developing an IRB for a study where we're going to start looking at this phenomenon at the cortical level as well as the peripheral level, to try to define what's going on here. So we don't quite know yet what the etiology of this is. Shockingly, there's only been 1 or 2 studies looking at this, which is mind-blowing to me.
Wow.
So we've got to define it first. But in theory, by utilizing Botox, in theory, we're kind of doing that, right? We're kind of taking out that abnormal pathway by putting Botox in that muscle and just shutting those nerves down.
Yeah.
That becomes the art of medicine, though, is you don't want to put so much in there that we weaken the ability to bring the arm down, right?
Yeah.
So we are kind of doing that, but no, it's a great question. Hopefully we'll get close to being able to define what the actual issue is, and then we can develop appropriate strategies. So again, within this model, though, we've got the health condition, which is the brachial plexus injury. We've got body function and structure, which is a weak upper extremity that can't go all the way overhead, and he's got limited range of motion. So we've got to work with that to improve activity levels and participation. And we've also got to take into account environmental factors and personal factors. So how supportive is the family? How much access do they have to physical therapy and occupational therapy? Are they compliant with those things? PT and OT. Are they participating in sports in lieu of PT and OT? Are they not participating in sports because of this, but they really want to? Okay, then we've got some personal factors we have to deal with there. Why are you not playing softball? Why are you not swimming? Why are you not doing these things that you can do? So again, we want to achieve this. We want them fully participating in life. So we have to work through these different areas to achieve that. And even seating clinic, when we look at wheelchairs for patients, that's a multidisciplinary approach, and it's all based on function. Why am I getting a wheelchair for this patient? What are they going to use it for? What is their functional goal for that chair? Is there something we can do less if the chair is not necessary? If their functional goal is to ambulate as much as they can, but use the chair to, say, go to the zoo or go on community outings, okay, that's a different type of chair than one they're going to be using all the time. So we goal set, even for things such as equipment, we goal set for what they want to use these things for. And we look at functional goals. And then there's even the medical side. I can have a patient who we really, really want to get them in a certain type of seating system in a wheelchair. But if I can tweak their spasticity and I can release a contracture and improve range of motion just a little bit to where they're going to sit better and be more comfortable, then I've got to do some medical interventions before we ever order that wheelchair for that patient, because I want them to use that chair. I want them to be comfortable in that chair, and I want them appropriately positioned in that chair. So there's even a medical side to looking at things such as wheelchairs, all taken into account for what we're trying to achieve. And there are different types of equipment out there. Everything from full-blown, yes, even dogs have wheelchairs. Full-blown systems. This is a young man who I followed previously who has SMA, and he is able to utilize this wheelchair through a hand toggle. He's got an environmental interaction system right here, and he's fully mobile in this system. Everything from full systems like that to adaptive walkers, to sit-stand systems, to wheelchairs with fifth wheels on them that power the chair forward. This is called a smart drive system. That's a powered wheel that the patient pushes the main wheel on the chair. The smart drive detects that motion, and there's a small motor in there that kicks in and provides propulsion to the chair. So one push of the large wheels and the patient can go 15, 20, 30 feet. You can modulate the effect of that smart drive system based on what your needs are. So there are all sorts of different things within the seating world too.
How close are we? I mean, you're much more involved from an academic standpoint. How close are we to miniaturizing exoskeletons for patients?
We're getting there.
Yeah.
We're getting there. Yeah. There's some really cool stuff out there right now. And the hand surgeon who I work with here is actually working with neural implants in the upper extremity for basically thought-driven control of the extremity. It's myoelectric driven, but it's driven through thought processes. So he's doing true neural integration with
Wow.
end systems, terminal systems. Yeah, it's pretty cool stuff. So we're getting there with all this stuff.
Yeah.
Yeah, it's a brave new world. So again, even in the world of seating systems, look at body function, structure, activities, participation, environmental factors, and personal factors for things such simple as wheelchairs. So how do you get to rehab? There are multiple routes to it. The basic route is you got to do a general PM&R residency, and that's open to MDs and DOs. So either allopathic medicine training, medical training, or osteopathic medical training is fine. Many DOs go into rehab medicine because of the musculoskeletal aspects of it, because of the whole person aspect. It fits within that sort of philosophical aspect of osteopathy. So many of my colleagues are DOs. I'm an MD because I was sort of late to the game. So general PM&R residency is 3 years following a 1-year transition year. That transition year can be in pediatrics, family medicine, general surgery, or internal medicine. So general transition year, and then that's 3 years of PM&R residency following that. That qualifies you to sit for the written board examination. And then 1 year after you start practice, you qualify for the oral exam. So you have to be in practice and you have to pass your written exam to qualify for the oral exam. We're one of the few subspecialties that utilizes oral examinations. I'm an oral examiner and I absolutely love it. I think it's a great test.
Yeah, sure.
Little stress provoking, but that's okay.
Yeah.
That's probably number 4 on the stress list.
Yeah. I mean, what other specialties still do orals? OB and ortho, I think, are 2 other ones. I think.
That may be it.
Yeah.
I think there's just 3 or 4 of us. Yeah.
Yeah.
Still do this. Still do it. And then once you've completed the general PM&R residency, if you just so desire to go into fellowship training, you can do that. We have AB PM&R certified subspecialties, fellowship training in brain injury. That's 1 year. Spinal cord injury, that's a 1-year fellowship. Spine disorders and musculoskeletal medicine, that's a 1-year fellowship. That's where you're learning about back pain. That's where you're getting spine interventional techniques such as epidural injections, facet injections for pain, ultrasound diagnoses for musculoskeletal based conditions and management of those conditions. We have pain fellowships. That's a 1-year fellowship as well. That's also interventionally based because many pain techniques are interventional techniques now. Sports medicine is also a favorite fellowship coming out of rehab. You can also get into spine, pain, sports medicine, brain injury, spinal cord injury out of neurology, out of orthopedic surgery. You can go into these fellowships as well from those subspecialties. And then pediatrics is also fellowship. We're a 2-year fellowship though, because there's that general pediatric background that many PM&R residents have got to do. And if they haven't had formal pediatric training, they've got to be trained in pediatric conditions. So we're a 2-year fellowship. And then we have multiple pathways to qualify for fellowship within pediatrics as well. You can do the general PM&R residency and a 2-year fellowship, or you can do what I did, which was 2 completely different residencies. That did allow me to sit for the board examination. Oops. There's more information on the AAPM&R website. This is the link to the website for medical students and residents. If they want more information about residencies or the fellowship programs, you can go to that link. Tons of information on our academy website. And our training is steeped heavily in neurology, neurophysiology, orthopedics, biomechanics, movement, musculoskeletal systems, and anatomy. And there are tons of residency programs nationwide. We do have residencies across the entire country. Many are clustered up in the Northeast or upper Midwest. That's where the original program started and then began filtering across the country as more programs developed. So a lot of programs out there to participate in. All of them are quite good and they're all varied in terms of what they teach.
What's up with OHSU? They don't have a PM&R yet out in Oregon? Slackers?
I think this is an older map, Ryan. I think they do actually. Yeah. Are you from Oregon?
No, I just
no.
It's a big program to not have one.
Yeah. No, I think they do now. I think they do now. And so, we are a little bit of a balancing act. We cut across different things, and we do rely upon team players to help us move forward with our patient care. So that's what I've got. I am definitely open to
I look
questions.
at that picture and I'm like, everyone's got to watch their calories every week because anything that throws off that homeostasis. Oh man. All right. We got time for maybe 1, maybe 2 quick questions. Sarah just asked the same thing about, or asked a question about oral exams, right? You're, as someone's going through this process, entering practice, the typical practice is you're gathering cases, right? Specific types of cases and what you're doing and outcomes. And then you get to go get grilled by senior level attendings that are like, why did you do this with this patient?
So we have our scenarios. We present 9 case scenarios, vignettes to the candidate. And the candidate, we walk the candidate through it. It's like 78-year-old man presents to your clinic with back pain. What do you want to know about the history and physical?
So it's not their own cases. You're presenting. Got it.
We're presenting. And I tell all our residents, when you do the orals, treat it as a consult. This stuff. Just think through it. So it's not bad.
That makes it more interesting. Like, why have it then? Because I can understand their own patients, their own cases. What's the difference between that versus just having those vignettes on their written boards?
Because what we're looking for really with the oral exams is thought processes. They're designed to basically assess their thought process.
Go a lot deeper.
So you can't really, we're not digging down in the weeds on details of pathophysiology or pharmacokinetics, things like that, like we do on the written exam. This is more, why would you order speech therapy for that patient?
Yeah.
Tell me
so it's not that you know the right answer. It's always like, I remembered because I studied my flashcards what the right answer is. It's like, do you know why that's the right answer? I want to understand that thought process.
Yep.
Got it. Yeah. Apparently that's important. Who knew?
Shockingly.
Yeah.
Right.
Let's try to get one person on here. Raise your hand. We'll unmute you and you can ask a question here with Dr. Rinaldi. If you want. If you don't want, I don't have to. Do that too. I guess nobody has questions. You answered all of their questions.
It's that simple.
Yeah, I think I saw one in chat. Let me pull up. Where'd that go?
hopefully everybody gets exposed to rehab at some point. It really is a wonderful field.
Yeah.
Very
All right.
fulfilling.
Naomi has her hand raised. We'll get
Yeah.
Naomi to ask a question.
Hi, Dr. Rinaldi. Thank you so much for this. I'm really interested in PM&R, so it was
Oh,
great
great.
hearing this.
Ah,
Yes.
good.
I was wondering, well, you spoke a lot about the transitions that families and patients go through when they're going post-injury back to home or hospitalization back to home.
Mhm.
Was that something that you feel that you gained a lot of knowledge about? Because the things that you mentioned are things that we take for granted, especially if you're able-bodied. So is that something that you felt was intrinsic to you, like as a PM&R physician, or is that something that you really had to really start to think more about in your training?
I think it's intrinsic, Naomi, in that most people who go into rehab, we tend to think that way anyways. So there's that intrinsic thought process of, okay, what do I have to do to get this patient home? I got to think about these things. The learning really comes in, what type of resources do I need to achieve that? What types of things do I think about, or do I have to think about to be able to achieve that? How do you design a ramp to get in the house? There are actually design specifications for that stuff. So that's where the learning comes in, is the how, not really the what. The what would probably be very intrinsic to you if you're interested in rehab, because most people already have sort of those thoughts in their heads. Yeah, it's a great question.
Cool. Thank you.
It's interesting. I had this conversation recently with a student who's going to medicine because their brother, I believe, has Down syndrome. I think CP something. It has some disability, and she obviously is a huge advocate and wants to advocate for those with special needs, and she was like, med schools need to teach more about this stuff. And I was sitting there thinking, like, do they? Because everything is so unique, right? Each individual disability and outcome that you're going for with each patient is so different that it's not really until you're in practice that you can figure out how, first of all, where am I in the world, right? Are you in rural Alabama where probably nothing is set up for a disabled person, a person with a disability, versus California, New England? I mean, nothing is really set up in this world for people with disabilities, but we're trying to make progress. I know that it made big news recently. There was some fancy library that was built in New York just recently, and the elevator, like, completely missed a floor. Like, it didn't stop at one of the floors. And like,
man.
the disabled community is like, you just don't want us to go to that floor? Like, what's in there? Like,
that's right.
What's going on?
We want to know now.
and so it's interesting, right? Being where you are in your career, is that something we can teach in medical school, or is it really like you just have to understand that there are barriers out in the quote unquote real world for these patients, and we just have to figure out the best way possible as you're out there to figure that out?
That's a fantastic question, Ryan. So in rehab, we get a toolkit. We talk about our toolkit all the time with our fellows and residents. You have a toolkit. That toolkit has tools in it that you can utilize to figure these things out. You may set up practice in Boise, Idaho, and when you get there, you're not going to know the resources. You're not really going to understand that community until you get there. Once you get there, you see these things, these problems, these barriers in the community. Okay, you've got a toolkit to address those, though, right? So you don't possibly know what those issues are going to be, but you've got the tools. We've trained you in these tools to address those things. You're right. Everybody's different. Every situation is unique. So we've got to, prepare them to deal with those. And that's what we do. We can't teach them every single scenario. Yeah. But you've got a toolkit that you can use to address those scenarios. Yeah.
Yeah. I mean, it's basically what medical school is for everyone. It's the tools to think about what you need to think about and how to find what you need to know, and then go out and do it. So.
Yep. Absolutely.
Dr. Bob Rinaldi, pediatric PM&R, physiatry, whatever word you come up with next year, we are ready for it. Thank you so much for coming on and sharing your wisdom.
Oh, my pleasure, Ryan. I appreciate it.
Have a good one. Thanks, everyone, for coming.
Bye.